Welcome everyone to our Maternal Health Learning and Innovation Center webinar today, Reproductive Wellness for Women with Chronic Conditions. My name is Alice Pollard and I'm the training coordinator for the Maternal Health Learning and Innovation Center. I'm so glad that you could join us today. We are looking forward to a really great discussion. I'm just going to go over a couple of logistical items. And as I do that, you are welcome to introduce yourself in chat. Tell us who you are and where you're calling in from so that we can see who has joined us today. As many of you know, the Maternal Health Learning and Innovation Center is a national resource center dedicated to accelerating evidence-informed interventions, advancing equitable maternal health outcomes through engagement, innovation, and policy. We have 7 different organizations that are partners in the Maternal Health Learning and Innovation Center. In addition to these partners, we have wonderful advocates all across the country that are working to advance maternal health, including you all. So we're so grateful for you taking the time to meet with us today. We are very grateful to the Health Resources and Services Administration for funding of the Maternal Health Learning and Innovation Center. We have just a couple of logistical items to go over today. We are recording this session, and recording and slides will be made available on our website, maternalhealthlearning.org, and will also be emailed to all registrants. All participants are muted, so you will remain muted for the length of the call. But we do want to hear your questions, comments, and feedback. So you are welcome to use either the Zoom chat feature or the Q&A to send in questions and comments throughout the presentation. We will have an evaluation survey at the end of the webinar, so please do complete that so we can be sure to get your ideas and thoughts for future webinars. So without further ado, I'm going to turn it over to our fabulous team of speakers that we have today. And first, I will turn it over to Dr. Sarah Verbiest, who will kick off the presentation.
Thank you so much. It's really exciting to be here today and share this with everyone. And my name is Sarah Verbiest, as was mentioned, and I work at the University of North Carolina at Chapel Hill in the School of Social Work, and I am part of the research team on this project. So we have an amazing research team on this project, and about half of us are presenting today, but we wanted to make sure that you could see everyone who's on our team. Some folks who you're not going to hear from today are Dr. Crystal Sine, Dr. Kristen Tully, Catherine Bryant, Erica Little, and Quay Adkins. And so we just wanted to lift them up, and this is their work as well. And I also wanted to start with an acknowledgement. We want to acknowledge that this land is Indigenous land and was first inhabited by the first peoples of this land, our American Indian people. This land was stolen from them. North Carolina is home to the largest population than any other state east of the Mississippi River. North Carolina is home to 8 state-recognized tribes, which include the Coharie Indian Tribe, the Halawassaponi Indian Tribe, the Waccamaw Siouan Indian Tribe, the Saponi Tribe, the Lumbee Tribe of North Carolina, the Meherrin Indian Nation, the Occaneechi Band of Saponi Indian Nation, the Eastern Band of the Cherokee Indians, and is home to the Tuscarora. We recognize and respect their brilliant gifts and contributions, past, present, and future. They are a living legacy. We want to acknowledge that the United States, including our institution, the University of North Carolina at Chapel Hill, was built by the labor and ingenuity of people who were enslaved. We recognize and respect their brilliant gifts and contributions, past, present, and future. Black Lives Matter. We acknowledge that we work in and live in systems that have intentionally benefited some people over others based on their identities. We pledge to do and be better, to do our part to be true allies for change and repairers of the breach. I also want to acknowledge our funder. Our project was funded through the Patient-Centered Outcomes Research Institute, a Eugene Washington PCORI Engagement Award, and we appreciate those generous resources.
Hi, everybody. Welcome. Thanks for being here. I'm Rachel Arudi. I'm an OBGYN at UNC and one of the researchers on this project. And I just wanted to talk to you about why the importance for why we did this research. And I think most of you all know that some of this, but we'll talk about the fact that pregnancy-related maternal deaths are deaths that occur during pregnancy or within 1 year of the end of pregnancy, and usually from a pregnancy complication or a chain of events initiated by the pregnancy or an aggravation of an unrelated condition by the physiologic events of pregnancy. And we know that in the US, this pregnancy-related mortality appears to be rising, and it's currently at 17.6 per 100,000 live births, which is unfortunately higher than in any other high-income nation. But maternal mortality is just the tip of the iceberg. For each woman who dies due to a pregnancy-related cause, many, many more suffer short-term and long-term morbidity. And some of these are, we call severe maternal morbidities, but even ones that we don't call severe can still have a significant impact on people's lives and their families' lives. And unfortunately, both mortality as well as severe morbidity are 2 to 3 times more common in non-Hispanic Black women and in Native American women versus non-Hispanic white women. And about 40 to 60% of this pregnancy-related morbidity and mortality is considered to be preventable, and is especially likely to be preventable when it is happening among women of color. So we know that we must do better, and especially for both Black identifying and Native American identifying families. Next slide. One of the factors that we feel leads to this increase in pregnancy-related morbidity and mortality is the rising prevalence of chronic conditions that is also happening in our country. So among reproductive individuals, we know things like hypertension, obesity, diabetes can all cause increases in the risk of maternal morbidity and mortality. And pregnant individuals are increasingly more likely to have these chronic conditions. So we know that about 43% of US women of reproductive age have at least one chronic condition that requires either frequent follow-up with their provider or regular medication use. And not surprisingly, Black and Native American individuals of reproductive age have more chronic conditions than non-Hispanic white individuals. And this is likely due to structural inequities, such as availability of healthy food, places to exercise, experiences with racism, and other things. For the past 2 decades, experts such as the American College of Obstetricians and Gynecologists and the Center for Disease Control and Prevention, as well as the American Academy of Family Physicians, have recommended that we must focus on upstream events to pregnancy in order to improve pregnancy, morbidity, and mortality. And so the types of prevention strategies that reduce or control the chronic conditions in populations of highest risk are thought to have the greatest potential to improve maternal morbidity and mortality. And even if a person that has a chronic condition isn't able to reduce that risk prior to conceiving, at least we feel providing them with information so that they can make an informed decision about conceiving, as we've said, with the eyes wide open, to be as best prepared as possible for what might need to happen during the pregnancy and how to stay healthy. Next slide. But it's not just about pregnancy. Whether or not an individual with a chronic condition desires to conceive, managing their chronic conditions and promoting their health is just a good in and of itself. And this is consistent with the reproductive justice framework, where anybody should have the right to attain their full health potential, regardless of any of their of any characteristic that they might have or any social position. And whether or not in this case they want to have children or not sure or don't want to have children. And so, but we know that if we improve health and well-being for all individuals who are capable of conceiving during their reproductive years, that this will automatically result in improvements in maternal morbidity and mortality. And more importantly, improvements in people and families' longevity and well-being. Next slide. And To add to that, we know that only 18 to 45% of individuals who have a chronic condition or women of reproductive age with chronic conditions actually report receiving preconception care. And also that less than 15% of all ambulatory care visits for reproductive age women in the US included any type of preconception or contraceptive services. And we should say that most of those services were contraception and not necessarily other preconception things. If specialty and primary care providers consider reproductive health and preconception care as outside of their scope of practice, and then reproductive health providers consider chronic disease management outside of their scope of practice, women with chronic conditions who are planning pregnancies may fall through these gaps and not receive the information and preventive services that they need. And these barriers are probably compounded for Black identifying and Native American identifying individuals who face well-documented institutional and provider bias that understandably hinders their trust and may impact the receipt of equitable care. And now I think I'm turning it over to Marissa to talk about how we designed the study and completed it.
Hi, everybody. My name is Marina Pearsall. I work at the University of North Carolina, and I was one of the project managers on this team. So I'm going to tell you a little bit about how we did this study. The aim of the study was to increase understanding of how Black and Native American women with chronic conditions think about their reproductive health decision-making, and also ways to optimize their health. So we really wanted to identify patient-centered, patient-designed strategies for testable and sustainable health practices, and kind of set building blocks in place to support future action. Next slide, please. So this is a little bit about who was involved in our study. We had 34 patient participants. They all identified as female, Black, or Native American and having one or more chronic conditions. This also includes a group of 5 community partners. You'll hear from 3 of them later on today. But these community partners were patient participants, but also intrinsically embedded in our research team. The women in this study came from 18 counties in North Carolina and 1 county in Ohio. So we had a pretty good geographic spread across the state. And you can see on the screen here some of the chronic conditions that they had. There was a wide variety of different conditions. So we were really able to hear about a lot of different types of experiences and the similarities, even in dealing with very different conditions. Another part of our team were 13 researcher clinician stakeholders. So these were public health professionals, researchers, and clinicians who all had expertise in this field. All of them were from North Carolina, and this was a multidisciplinary team that could provide another perspective on some of the challenges in this space. Okay, so these were our methods. With the participants, we had held 2 focus groups. So the first focus group really focused on the challenges and all of the issues around preconception care, preconception health, and chronic condition care. So we learned a lot about their current experiences and challenges in that group. And then the second focus group really was more forward-looking, and that was focusing more on strategies for improved care and ideas for research, like what we can change going forward. We also held 2 sessions with our researcher clinician stakeholders, and they had similar themes. So the first session, we spoke with them more about the data and what we were seeing with our focus groups. And we talked a lot about care challenges and opportunities from their perspective. And then in the second session, again, we focused on strategies moving forward. We had a final convening, which was really cool, where we brought everybody together. So our research team, our community partners and patient participants, and also the researcher clinician stakeholders. And everyone came together for a long session where we talked about what we had learned together and talked about strategies moving forward. So really, how can we change things in the future? So we had a pretty unique approach for this type of work. All of our focus groups and gatherings were held virtually. Initially, we had planned that due to the pandemic, but we ended up getting a lot of feedback from participants that worked well for their schedules. We were able to hold focus groups on Saturday mornings and weeknight evenings and really try and fit their needs. We also had rolling focus groups, which was a way to keep participants engaged, and they could attend a focus group whenever they were available. So even though we wanted them to attend each of those 2 sessions, we were holding them at a variety of different times throughout the months of this project. So, if they couldn't make something due to what was going on in their life, like they would still be able to attend a focus group later. We also had what we called walking to the parking lot time. So the intention behind this was to kind of emulate the time in a real life focus group where you might, finish up and then have a few minutes to walk to your car. And this was a time where we turned off our recordings and, we let participants know that the recording was off. And there was really time to decompress and sort of transition back to real life. This was helpful because a lot of participants shared traumatic and very emotional stories and experiences. And so instead of just, ending the session and turning off Zoom, we had a few minutes to kind of decompress together. We also held a research webinar. So that was an hour where our team met and recorded a session where we went over research methods, how patient-centered research works, what we were going to be doing in our study. And then we sent that to participants and they could watch that on their own time. One really cool aspect of this project was we had graphic facilitators who were present at several sessions with participants, and we'll share with you what that looked like a little bit later. But that was basically we had a graphic facilitator or a graphic note taker rather present who was visually depicting the themes and experiences that folks were sharing like live on the screen while we were in our session, and that really kept everybody really engaged. And then lastly, we had a continuous feedback loops with community partners. So our community partners who were also participants themselves were embedded in our research team. We met with them at least monthly. And that was really a highlight for me in this project, just getting to be so engaged and connected with them. And they really helped drive our project forward and help us with our research and how to structure things and what to focus on going forward. Okay, and then these were some of the ways we focused on building community in this project. We had newsletters that we sent out to participants on a monthly basis or so, and we shared updates from our research team, events and resources that were relevant to their needs that they had told us about, and kind of shared a little bit about our team in each newsletter. And that was just a way of keeping everybody engaged in between the sessions that they were attending. We also started a private Facebook group just for the participants themselves and our team. And that was a way for them to be able to connect with each other. A lot of them had shared experiences. And it was also a way for us to share and stay connected after our project ended. So, we still have that Facebook group today.
All right. I'm Melissa Richardson, and I will be one of the stakeholders, as well as a participant that's helping to present with this awesome research team today. And so first we wanted to share what one of the things that Marina alluded to a moment ago was this very cool graphic note-taking that we all got to participate in. And one of these is here sharing on the screen, and really reflects the challenge and the opportunities that we were attempting to design some strategies for in participating in this study. So one of the things I want to just immediately call out is many of the participants, upon seeing this graphic, felt that it was very chaotic. And that was very reflective of the reproductive journey in general. Sometimes it can be very chaotic and involve many, many facets, as you can see really reflected here really uniquely by the graphic artist. A couple of things, and Erica and Shawnette and myself are going to all chime in on these next couple of slides, but a couple of things that stand out to me as both a stakeholder and a participant. Firstly was just sometimes the negative psychological impacts that can occur during the reproductive journey in general, and the stress of that, and how that not only impacts your mental health, but it also can manifest into the physical health as well. So a lot of our participants shared quite a bit around that. The other thing was for me that really stands out on this graphic is somewhat of a disconnect between sometimes between the primary care physician and the specialist. And then me as a patient, maybe not feeling like someone is looking at me in a holistic way. So somewhat of a disconnect in my care. And certainly I experienced that many, many times throughout my reproductive journey, and felt that we were always missing something. Something was always being missed because there was just this disconnect between all of my providers, and there are several. So having that connection, especially in cases where someone might not be as much of an engaged patient. I consider myself pretty engaged as a patient and pretty good of an advocate for myself as a patient, but I do realize that everyone's not like that. And so when you don't have that level of advocacy for yourself, you do feel a bit intimidated. And sometimes that can also cause and result in even more of a disconnect and a feeling of stress and not being able to feel heard and connected with your providers and your care. Erica?
Thank you, Melissa. I think there are some other slides that may be coming up next that has some quotes. So I think the team, hello, I should have said this when I started. My full name is Erica Chambers, and I am one of the patient research stakeholders. I got that out of the way. But if they're able to advance the slides, there were really cool quotes that folks tell you one that stuck out to me and I wanted to talk about, and it was how when you receive a diagnosis, a serious diagnosis, and a condition that will impact you for the rest of your life, it could be very overwhelming. It can also be very scary. And so when you are talking to physicians about your overall wellness and your reproductive health, many of our peers throughout the focus group said, we wanted to hear the information about what was happening to us. We knew it was serious, but we did not want it to be the end of the world. We did not want it to be the end of all the good things that are to come throughout the rest of our lives. So what can we share with clinicians and other providers to understand that we are human first, and our conditions do not identify us. They are a part of our lived experience, but we work very hard to make sure that we live full and rich lives. So I say all that to say, it was really important for us to not have information that was sugar-coated, but to just have providers understand that we still need to hear encouraging information. We still want to be encouraged. We want to not only address our disease, but we want you to focus on the quality of our lives as well. whether or not you want to be a parent or not. And a huge part of this that Melissa alluded to was around support systems and having coordinated care, because we oftentimes found that because of the silos in the clinical space, you have to repeat your story of impact over and over and over and over again. And that is exhausting. That is exhausting. So having providers that are better coordinated, that are well informed, and also can create support systems as we navigate these spaces where they consider not only our illness, our chronic condition, but they think about our emotional, physical, and yes, financial well-being too, because you're being hit with a lot of information and they say, go off and do this or take this test. But you're like, where do I even start? So just having support systems put in place and intentionally and more upfront would be very helpful. And that came out over and over again with my peers as we just started to discuss our different experiences in trying to navigate the healthcare system with different health issues. Shawnette, I'm going to go ahead and turn it over to you so that you can tell a little bit about your perspective and your story when we were engaging with each other throughout the focus groups.
Hi, I'm Shawnette Howard. I'm a doula, as well as one of the stakeholders and participants in the study. And this, honestly, emotionally creates a lot of weight. Some of the things that are depicted in the journey picture here were education, early education, not just education, earlier education, and how information is being given. I have my own ailments that lent some of the emotions that you feel when you're one of the people in the participating group, but also trying to pull what people are actually feeling about their health care. And a lot of people found a lot of taboo around just the information. Anything dealing with reproductive health was not discussed in their homes because it was, ooh, I don't want to talk about that. Or it has been a lack of understanding. So instead of being able to understand and give the information to each other generationally, a lot of women and people found that they really trusted their doctors to do this because they didn't have the space in their own homes or in families. So early education is really important because the earlier we know about our body, the more we can do to prevent things. And that's a huge thing is, well, why didn't I know this information so that I wouldn't have to take this journey or be more prepared for this journey? Preparation for the journey is key to hopefully ending the issues or finding ways to help the issues. How do I know what to go to the doctors for if I don't know my body and what's going on or the information that I need? And then for providers to trust that the person knows their body. I live in this every day. Tell me why I'm feeling what I'm feeling. Don't dismiss what I'm feeling. With some of my ailments, it's very, there's some things that are kind of like, oh, you're okay. And that's kind of an overhauling thing is, are you okay? Am I okay? How can we make this better? So working together to help give just a clarity for women and people to feel confident about their health.
And I think we're on the next slide. After our group findings, there is some information and it's in another infographic right there. Let me see. I believe it's, yes, this one right here. I thought the artist, I mean, she was amazing. Like, we were talking 1,000 miles per minute, and this woman, she was just sketching away. So here you see just some of the major themes that she captured from us when we were talking about what are our ideas about how to improve this? How are you feeling now? How have you felt throughout this process? And if you could actually tell clinicians something right now, what would it be? And one of the things that I wanted to highlight is this vision that we talked about together. And they were saying like, well, what would it look like? And we're like, we need some type of like comprehensive reproductive health and wellness center. Like, we need something that focuses first on reproductive health wellness and build everything else around it. For example, yes, we want to have chronic care specialists in this wellness center. We want to have OBGYNs, endocrinologists, folks who work with lupus, sickle cell anemia, any of those diseases to work alongside primary care. And if possible, it would be really nice if they weren't so spread out. Like, I'm not just talking spread out geographically. I'm talking about spread out in terms of information sharing. Like, well, okay, so I need to send another message to this doctor, and this doctor too, about this same situation. Nobody in the system knows what the other doctors think, So it's just important to think first about the issues around reproductive wellness and how everyone else can come alongside and support people along their journeys, because it's so important. Also, we talked about the space definitely needs to be like a one-stop shop so that you can have folks who can talk to us about the hard things. Like, and I think that's on the next slide. There's another set of yes, here, that was so awesome. Like, she created like these note charts, like, these are notes. Hello, you need to make sure that you pay attention because it's important. And on here, we talked about like how if we had something that was more comprehensive, like a reproductive health and wellness center, how we could think about how we could share information across multiple systems. We all like using our cell phones, being on the internet, but sometimes I want to pick up a piece of paper and I need to highlight things and read it, but it does not need a lot of medical jargon. Like, not only not medical jargon on print, whether that be on paper or online, but also with your provider. Because when people start talking to you about your chronic health condition or your diagnosis, and they're using a lot of medical jargon, you're not listening to that. You're like, wait a minute, back up. You just told me this is what's going on with me. Like, let's stay here first, and then break that down in more simple language, and then talk to me about everything else. And we found that happen with a lot of us. They were talking like down to us in like high level medical jargon, and it just makes you feel uneducated or like you're stupid. And we know we're not. We know we're not. So just having information come across in a way that's relatable to where we are socially, emotionally, culturally. We really want that. And so, yes, get rid of the medical jargon. We want something that's comprehensive. And we also need someone that wants to talk about the finances. Like, nobody wants to talk about insurance and tests and infertility and loss and those things that come along with it, but they all want us to be able to fix ourselves and to have these healthy lives and to follow all of their orders. And it's like, but these things, we live in America. These things cost money. We need to have these conversations. I mean, and I just kept saying it over and over. And I'm like, can you tell me how much that costs? And they were like, well, we don't know. Who knows? So we decided it was important to put that as a big topic at the top on the right side where it says with respect, with financial support, with empathy, because it was just a huge part of our journeys. So I hope I hit on that. Shawnette and Melissa, please feel free to chime in, but I know we just had a lot of conversation about that and it was really important. There's something else that we need to highlight. I'm going to turn off this mic and let you guys talk about it too, because it was a really serious issue. It was.
You are
I
just fine,
definitely want to
Erica.
piggyback on that.
Yeah, I'm sure we both do. Shawnette, would you like to start?
I do. I think the key word is trust in what Erica brought up. And when your provider is showing those types of biases, you don't feel comfortable to give all of the information that you have. If I don't feel heard, or if I don't feel like someone is taking me seriously, as many others do, you tend to draw back and not give as much information as possible. You can kind of see, I know in my work, I can kind of see the difference between peer support information and clinical support. And there's a big gap there. In peer support, you'll tend to get everything because a mother or a person is pouring out their soul, their everything they're feeling. So when providers don't treat a person as a person and equally as a person, whether it's their race, whether it's their age is a big one. I personally experienced this recently with my last birth, and just kind of being lumped into you're this old, so you're going to have these issues, so we're going to treat you as such, as opposed to a holistic, hey, let's look at your whole body, because even though your age is this, these may not be your concerns. One of the quotes, as you see up here, nobody took me seriously. I don't know if it was because I was Black, or because I was young, or because I was a woman. They weren't listening. They weren't taking me seriously. And that, it's hard to say the quote, but I resonated with this quote. Many resonate with this quote. Weight discrimination. When you look at a person, I know we have this in society where you look at a person and you just assume, oh, they're not healthy because they look like this. And I've seen many a example of two people, one quote unquote skinny and one quote unquote on the heavier side, and the heavier person has more stamina, more whatever, their panels look great. It's not fair to a person who is in a weight class to be classified as unhealthy without any of those things proven, or how to get healthy, or how to create a better, healthier lifestyle, without just assuming, oh, you eat trash, don't you? Because you're heavy. And I experienced that as well. So when you cycle around this idea of, this is what I see, this is what I'm going to give, then you're not treating the whole person. Thus, you have to actually care about the person enough to get deep with the person. I'm not saying everybody needs 2 hours to do this, but there's an element of taking a little bit of time to actually hear a person and not just see them. So I'm going to go ahead and turn that over.
That's great, Shawnette. And if we could back up one slide from this one. Again, just to reiterate all of what has been shared, this quote was also very powerful in terms of mental health and the negative effects. In terms of mental health, the anxiety I feel like I have developed as a result of chasing down diagnoses and having to advocate for myself in fear, absolute fear of going to the hospital because I'm worried there's a conspiracy against women of color to even have babies. It doesn't even seem like people want us to have babies with the way we are treated. That was so powerful, and just such a reflection of how the biases that exist in systems also just play into such strain and stress on what is already a very challenging at times situation with reproductive health, and a very challenging time during a birth, and you're already very emotionally charged and stressed around that event in general. And one other big one, not feeling seen or heard. In the journey slide, trust, you saw that kind of in big in the middle of that graphic, and trust just kept bubbling up to the top. It was just very, very important, and just so meaningful to our participants and those who participated in the study, that they trust their provider, hearing the information from someone that they trust. And if that wasn't established, it was almost like it just there was already something that couldn't be accomplished if you didn't have trust with the provider to begin with. And I'll also add, it was really interesting how the groups, in sharing these very heavy and emotional, traumatic things that had occurred, the groups just very organically came together in support. And so that was just very striking to me as a participant and as a stakeholder, in how they just came together, women who had never met, but had very similar and yet unique experiences, but felt very together in the midst of those groups, and felt very comfortable. Once people started sharing, then it was like the floodgates opened, and we just got more and more and more from people. So it was really meaningful in that way as well. If we could go ahead and advance to slide 21, the solutions. Here we are. Yep, strategies for change. So we're going to talk about those next. And so as we've already alluded to, and I'll start, Erica and Shawnette, and y'all can chime in. One of the big things that came out as a good strategy was really mimicking comprehensive care models, such as the cancer care model or the diabetes care model, where you have a comprehensive level of care amongst many specialists and primary care providers together, that also included the financial, that also included the psychological and mental health pieces. So kind of an inclusive care model where women could really travel back and forth through that journey in one comprehensive place, so to speak, whether that included virtual spaces for some providers, or one physical space where providers floated in and out, but the patient stayed in the center of that, and providers could come in and out to help with the care of that patient. Erica, Shawnette?
I'm gonna keep it quick so we can have some room for Q&A. And to me, the most important thing that I think you hear from all of us in saying is that care needs to be better coordinated. We need care that is more culturally relevant, and we need people in spaces who are not always the provider. You need other people's doulas, social workers, other peer support. We got so much from having other people to lean on and cry to, that we're going through the same experiences as us on this journey of reproductive health with a chronic health condition. So that's very important. And lastly, in terms of like design and implementation and how to look at impact, we know that clinicians and providers and people in clinical medicine and public health, we're always looking at how to measure things, but it's really important in that journey when you're looking at quality improvement strategies, come talk to us and ask us, like, what do we see as impact? How do we know we've gotten better? What does that really mean for us? And with that said, I'm going to turn it over to Shanat if you have anything else. And if not, then Rachel can feel free to jump in so people can start to ask questions. But I just wanted to say that part because it was really important. And it's something that we came away with about the importance of keeping us centered in all these design processes.
Right, Erica. I will keep it quick too, because this is a deep, it's a deep thing and all. One of the things that one can assume is that the people that we had in the research were mainly low income. I think in my mind myself, like, oh, we don't have access because of our income, when clearly across the board we had women of many backgrounds, many educational levels, and they had the same issues as women in the low income brackets. And so that tells us that it's not an issue of can they afford, it's an issue of is it there for them. One of the things that was mentioned was as far as this, maybe the quarterbacks, kind of that ideal is going into care with a, hey, let's get a full panel. Let's see what you look like on the inside. And then having a discussion around that panel of what you look like on the inside and what you're feeling and how can we come up with a plan with that. And having, as they were saying before, just everyone pitch in, and this can be done digitally. This doesn't have to be, we all sit at a round table and we have a discussion. No, this can be done digitally with that person being involved in their health. And I think that's a big deal, is pulling the patient back into their health again, pulling them, knowing who they are and what their body is doing. But that's pretty much it. I would love to pass this on so that we can get to questions and all.
So we just briefly learned a lot, the researchers as well as patient stakeholders. And I, for one, am really, really grateful for the value of the time and emotion that was put into this. So thankful for it. I think one thing that I really want to say here is that research can be a healing space. This was like kind of revolutionary for me. Research doesn't have to be about taking from communities. It can be about healing. And this research seemed to be healing for a lot of the people who participated. And so I would encourage you all to think about ways that your research or QI can be healing. And I also wanted to just say that we learned that it was really important to be inclusive around the types of conditions that we're thinking about, because what's important to patients may be different than what providers perceive as important, but it's all, as they've so eloquently said, part of who they are. Like, it's holistic. So whether it's PCOS or fibroids or heart disease or kidney disease or cancer, whatever a patient perceives to be a chronic condition that's impacting their reproductive health should be considered to be in, a topic in these conversations. And I'll pass it on to Sarah.
Thank you. And I think one other thing just to highlight on this slide and overall is that, sometimes the word preconception care has gotten a bad rap. But what I learned from this project is that it is reproductive justice. People aren't going to even be able to get to the MCH space because of miscarriage, infertility, and loss if they don't have this really, really important care and service. Next slide. So I'm just going to highlight two different quick things because the team wanted to share this, because these are some two different studies, and what we learned really connects to what we heard from this group. So in one project funded by the W.K. Kellogg Foundation, we listened to different groups of people, payers, specialty providers, primary care providers, policymakers on this topic. And I wanted to highlight that, their findings also said that we really need to have women's reproductive health and women's healthcare should be part of basic training and board standards, so people don't get caught in this hot potato effect that you've heard us talk about a fair bit today. And they also identified that there are innovative models out there that really need to become standard of care and really need to be put into action. We know how to give better care, and we really need to move to doing that. And then they also noted that we need some incentives for those conversations, because as you all have heard, to have a reproductive intention or reproductive wellness conversation, it takes time. And so we need to have ways to have some, financial incentives and other incentives for healthcare providers to have those conversations. Next slide. And then we also have done a national survey on preconception health, and we had 1,500 people who identified as women who responded. And highlight, we were not expecting that 56% of the people that responded to the survey said that they had one or more chronic conditions, which is really astonishing. We were not sampling for that at all. And the majority of those people did not receive any counseling about their reproductive health. So this really just is like turn up the volume on what you all heard from the voices of the women that we were in community with. But people think it's important, and people don't understand that what is their health before pregnancy has an impact. So this is something people aren't getting, something they want, something that they need. And they also underscored what we heard is that people really need this education from a healthcare provider, and they need to be in relationship with the healthcare system so they can get answers and responses and questions answered. Next slide. We're going to not talk about these so we can get to questions, but we do have resources available on the shareyourlovetoday.com website for consumers on lots of different health topics. Next slide. And we also have resources for clinicians, some training modules. So you can get working on what we've been telling you to do. And it's on that website. Next slide. And next slide. We also have a newsletter, but you can have these slides. And then Marina, I'm going to let you close out with this slide, and then we'll move to questions.
This is just kind of a final depiction of how we closed one of our sessions, which was letting participants just share with each other their hopes and their wishes for one another. And it was really kind of a feeling of warmth and community. So we wanted to share that with you and show you what it looked like. But if anybody has any questions, feel free to put those in the chat box, and we would all love to have an additional conversation.
I think one question we can say right now is that someone was asking how you would recommend discussing this with your providers, and maybe which providers, because they brought up OB providers maybe versus other providers. I think this is out to Melissa, Erica, and Shawnette.
I was just about to say, I think the direction is usually pointed to your primary care, because if you're looking for, okay, I don't know what's wrong with me, you don't know what specialist to go visit. So if your primary care is your baseline, then they can send you, just like with regular referral processes, but have it streamlined back so that it's not just kind of like, oh, I went to the specialist and now I'm with the specialist, and I went to this one and now I'm with this one. It has to somehow come back together so that they can work together to get this person, to get you what you need.
I agree. And I would just add with the primary care physician, and we talked about this quarterback, and, I talked about this example for me with going through, the oncology system. And so like you have like a medical oncologist, an endocrinologist, a radiation oncologist, a surgical oncologist, and all these other folks who are involved with my care. And they've decided that the primary care physician, along with my medical oncologist, would be my quarterbacks. From there, everything else is built around the support that I need. But it was overwhelming at first until I just had to come out and ask them, like, which one of you am I supposed to come talk to first? Like, I don't even, who am I supposed to talk to? So again, starting with that, and I do agree, in some situations for a lot of people, your first introduction into care is through an OB. So sometimes you do need to advocate and tell your OB, I think something is wrong with me, and I need help getting to the right person who can help me figure out how to coordinate the rest of this stuff. If it's not you, do not leave out of that office without that kind of answer. You need to know where to go to next and have the courage to just get honest and say, no, this is not okay. Thank you for your help. How does this connect to everyone else? And I need your help with helping me to figure that out. So just advocating and sharing that with your provider so that they can better help you now is really important.
There was another question about would there be a conference or a smaller meeting, or could we collaborate with the hospital and other healthcare facilities to voice our concerns? And I just wanted to say on that, yes, I think one of the things we learned from the providers that were involved is providers have a lot to learn and we have a lot of improvement to make, but most of the providers desire to do better. It's not that anybody desired to do a poor job. It's just that there's kind of a like we're missing each other. We're not listening well. We don't have time, lots of things. So I think there are a lot of providers out there based on our experience that would be really receptive to having these discussions. And I would suggest finding a provider champion within a health system or a clinic that's really interested in this topic and working, like in our experience, partnering with patients and providers who really care about this to kind of bring the news more widely to other people. I don't know if anyone else has thoughts on that.
Great. In terms of the question from Lauren, I think any of us could answer that. I want to say from my perspective, the relationship that we have with this team is beautiful, and it was something I loved coming to and have always, this has been the most meaningful thing I think I've ever done, and I remain committed to keeping the band together. And so I think that part of what was great is we invested time in our relationship, which was really important. And our team made all the decisions together. And actually, Melissa, Erica, Shawnette, and Quay, they just stepped in and did the facilitation, which was way better. Anyways, Marina, if do you want to, and the recruiting, Marina, do you want to talk about that, or Melissa or somebody real quick, and the compensation?
Yeah, I guess I would just add about the recruiting that it was difficult to identify patient participants, and that's kind of reflective of the difficulty and how, there's a lack of connection here. But our community partners we see on this call, and also Quay, helped a lot with that. We really helped with their networks that they had, and so we really just tried to use the networks that we had and connections that we already had, but it was difficult.
So I know we're at time, but I wanted to have Melissa, or go ahead, Rachel, and then maybe.
Well, I was just going to say, yes, it was very important for us to compensate them, and we tried to compensate them well for their time, like commensurate with any other research expert, because they're experts of the community and of as they said, they're experts of their bodies. And so their expertise should not be seen as any different than my expertise as a physician, for example. And also that being said, some of our recruitment did work well with personal invitations from providers to patients that they had relationships with.
And I know we are summarizing our recommendations. We're writing a paper together, and we will be happy to share this with anybody that wants to talk to us, right, team? We have this recording, so we're happy to go on the road. I'll say, please do the evaluation for the webinar, and then I know we're late, but I want to turn it over to Melissa or Shawnette or Erica for the final words.
I would just like to say that I appreciate everyone joining today. And really, you can just see from the comments in the chat and the questions that so many people also care as deeply about this work and these issues as we do on this panel and in this research team. And it's just, it's really great when you've gone through something and hearing other people care about it, but certainly on this level, seeing so much support and so many people that care about this work and want to see things continue to happen with this type of research. So thank you.
And I'll just say thank you to everyone that's listening, and thank you to this team for really putting into action what patient-centered care can look like when you actually want to consider the voices of patients to do the work. at all stages of the reproductive journey. Because oftentimes we get to mothers or women who are persons who have lost an infant, and there's this wide range of us that are in this space with all these different chronic illnesses, and you guys really were intentional about that. So thank you. I'll say to anyone else, you guys are rock stars for being so inclusive of all conditions impacting us in this space. So thank you.
Same here. I actually saw a question that I will ask about later, but Joan Cox had a question about insurances and how it limits the time with the patient. And I think this type of research will help bring together insurances and healthcare so that we know, I know time is money, but time is also health. We only have a certain amount of time here, and we need to take it seriously. And I really appreciate this study, the people that are in this study, the people that who gave their time. They gave wholeheartedly. There's always this wonder of, we're doing it virtually, are we all going to be able to meet? But everyone was excited about meeting together. And our facilitators, oh my goodness, I will be forever in contact and working alongside them. So I really appreciate everything that's gone into this.
Thanks, everyone. Have a great day.
Thanks everyone for joining, and thanks to our wonderful presenters. Please be on the lookout for an email with the recording and all the information. Thank you.